Hello class. The medication that I have chosen for this assignment is called Breo. It can be viewed both on TV and online. Basically, it's about a minute long and begins with a lovely looking group of elderly gray-haired people viewed in their normal working situations as they begin by introducing themselves by saying, "I am Jane, Jane, then Dave, Dave, etc. Ultimately, with the last person saying, "I am Kate, Kate, and I have COPD. But I don't want COPD to get in the way of my volunteering, and that's why I asked my doctor for Breo." Then the ad changes to a more descriptive narrative voice of a man saying, "Once daily, Breo helps increase airflow in the lungs for full 24 hours, and it goes on to say how it helps to reduce symptom flare-ups that can create hospital stays, etc. He then says it's not for asthma and how it has a type of medication in it that increases the probability of death if used in people with asthma. This warning is the same lovely selling voice. It goes on to say it won't replace rescue inhalers and how it should not be used more than once a day, and how it may increase your risk for pneumonia, thrush, or osteoporosis, and some eye problems. He also says, tell your doctor if you have a heart condition or blood pressure before taking Breo. And then finally he says, then it goes on to say, your first prescription is free at mybreo.com. The product insert, of course, has a lot more information on it than does the warm and fuzzy commercial. This includes a black box warning about asthma-related death, which I will elaborate on in a bit. The product insert does confirm that it is used for COPD and that it is a one-time dose, as mentioned in the commercial. The product insert is considerably more involved in terms of information, contraindications, and warnings than the commercial. The product insert consists of 40 pages, whereas the commercial was 1 minute long. It goes on to tell you about multiple drug and food interactions, the mechanism of action, as well as the reviews and clinical studies that are, quite frankly, only a healthcare provider would be able to interpret. If a patient with COPD came to me and requested this medication, I would explain to him or her that this is a relatively new medication approved by the FDA to treat chronic obstructive pulmonary disease. The drug fluoxazone, furoate, and vilanterol combination powder is meant for long-term maintenance of airflow obstruction in COPD patients, including those with chronic bronchitis and emphysema. Breo is also indicated to reduce exacerbations of COPD in patients with a history of exacerbations. Approval was based on trials of 7,700 patients with a clinical diagnosis of COPD. The newly approved product contains 1,000 micrograms of the inhaled corticosteroid fluoxetine and a nasal spray, which has already been approved for the treatment of allergic rhinitis, and 25 micrograms of vilanterol, not previously approved by the FDA. The product is delivered in a dry powder via a novel Ellipta inhaler device. Experts have expressed concerns, however, that vilanterol, the long-acting beta agonist, LABA, component of the combination drug, provided nearly all of the clinical benefits. Fluoxazone provided less clinical benefits according to the trials studying individual components of the drug. Other concerns with the drug is the risk of pneumonia and bone fractures. Although it is thought that a once daily use could improve medication adherence. That was one of the benefits. The FDA's approval requires a black box warning that LABAs increase the risk of asthma-related deaths. The FDA has approved 2 other inhaled corticosteroids LABA combination products for COPD, Advair and Symbicort. Both are used twice daily, whereas Breo is once daily. Also on the market for once daily use is the long-acting antimuscarinic agent Spiriva. I would encourage my patients to continue use of their current regimen, particularly if it was working, because the newness of the drug coupled with the black box warning is concerning to me. The pharmaceutical industry is a $300 billion a year industry that spends $3.1 billion on advertising prescription drugs to consumers. Since 1962, these ads have been regulated by the Food and Drug Administration to ensure they are not misleading. The U.S. and New Zealand are the only two countries where direct consumer advertising of prescription drugs is legalized. Proponents of direct consumer drug advertising contend that the ads inform patients about disease and the possible treatments, encourages people to seek medical advice, helps remove stigma associated with medical conditions, and provides needed sales revenue to fund costly research and development of new drugs. Opponents contend that direct consumer drug ads misinform patients, promote drugs before long-term safety profiles can be known, medicalize and stigmatize normal conditions and bodily functions like wrinkles and low testosterone, waste valuable medical appointment time, and have led to our society's overuse of prescription drugs. I can personally see both arguments, but overall, I feel that prescription drugs are overused and therefore should not be advertised. I could use pharmaceutical advertising to my patients' advantage by using these opportunities as teaching opportunities for my patients, so when questions are asked about medications, it leads to further discussion about the disease process. Thank you very much for your time.